Start. Good morning, ladies and gentlemen. Thank you very much for joining us on this rather cold November morning. My name is Tulip Mazumdar. I'm the BBC's Global Health Correspondent. I'm chairing the event today. Firstly, many thanks to the Bill and Melinda Gates Foundation for having us here at their rather swanky building. Rolls-Royce, I think, is downstairs. On behalf of BBC Media Action, the BBC's international development charity, it is a pleasure to welcome you and our panel here to this event. It's all to coincide with Media Action's new policy briefing, which I'm sure, I think you've got that in front of you, and do have a read of it if you haven't already. Coming of Age, Communications Role Empowering Global Health. Our meeting will begin with some questions to the panel, followed by an opportunity for you to ask questions. So do think of things and write things down as we go. We are also live streaming the event on YouTube. So I think this is the camera here we're looking at. So welcome to our viewers that are looking online. We'll be live tweeting throughout. So you can use the hashtag #DiscussHealth, both people watching online and people here as well. It'll be good to get some chat going on the internet about this event. But if you do have your phones and you are doing that, then please keep it on silent. For those of you who probably don't know, I spent quite a bit of time in 2014 and 2015 in the worst affected countries in West Africa reporting on the Ebola outbreak. And what was very clear to me was how important communication is. It was good communication, in my view, that helped end that outbreak. Going around some of those villages, I was in Gekadu, close to where the outbreak started in July 2014, and I have never felt fear like I did in that place. Fear of those communities, uncertainty, not knowing the right thing to do, desperate to protect their families but not knowing how to do it. And when the information did start flowing in the correct way, things turned around pretty quickly. I think most people here and in the audience as well will agree communication's a good thing, but we're really here to discuss how good a thing, how does it compare to other interventions, and how high up the agenda is it, how high up the agenda should it be. So let's go to our panel. I'll introduce everybody. To my right, we have Professor Peter Piot. He's Director and Handa Professor of Global Health at the London School of Hygiene and Tropical Medicine. To my left, we have Elizabeth Fox, Deputy Coordinator, Child and Maternal Survival and Director at the Office of Infectious Diseases at USAID. Everybody's got quite long titles. Dr. Gaya M, Manager, Interventions and Guidance, Infectious Hazard Management at the World Health Organization Health Emergencies Programme. Dr. Raphael Obregon, Chief Communication for Development at UNICEF. We have Dan Metcalf on the end there, Head of Brand and Campaigns at the Wellcome Trust. And last but by no means least, Caroline Sugg, Head of Special Projects at BBC Media Action, who is very much behind the policy briefing you have in front of you today. So let's just start with the question about communication. What we all acknowledge it's important. Why? Why is communication so important with global health? We'll start with you, Professor Piot.
Thank you very much, Tulip. And let me first say that commend Caroline for a very good paper. And I'm saying that because particularly when I was head of UNAIDS, I always thought that communication was a no-brainer, but often the people who are dealing with communication were unable to tell me and to explain to me in words that are understandable for a non-communicator, what they want to do and what the purpose is. So I really thought that was a very good paper that is a solid base for the future and for our discussions. To say that, I always think it and communication for what. It's not a purpose in itself, and I see a few levels. And the first one is not really addressed in the paper, but I think has also been very important when it comes to global health and health in general, and that is communication to decision makers. Because when we talk about social and behavioral science and change and so on, that's also an audience that we shouldn't forget. And because they can be either facilitators or supporters or total obstacles. And that's something that has been really important when in my own life when it came to HIV, to turning it around from complete denial, from not wanting to deal with difficult issues around sex and drugs and so on. I'm not saying it's done, but that's been a really important part of communication and probably where we've had quite some impact. Secondly, it is about behavior, and that would be better addressed by others, I think. But the point I want to make there also, again, on my HIV experience, is that it's not only about changing behavior. Adolescents at the moment, particularly in sub-Saharan Africa, are the #1 vulnerable group, particularly young women. And for them, when you're 14 or 15, it's not about changing your behavior. It is about adopting, maintaining behaviors that were not risky. And so that is, I think, a very important message that we also should bring. And I'm quite now pleased that we have far more evidence than we had before that this really works. Because, and I'll come back to that when we talk about AIDS, but particularly in the biomedical community, and it's also mentioned in the background paper, people think the only thing that works is what passed a randomized controlled trial and so on. And at our school, in the London School of Hygiene Tropical Medicine, we are the temple of that because it was invented in it. But I know that there are other ways of proving that something works. But, you know, we have also very hard evidence that communication works. The last one that I saw is quite a bit, maybe a bit unexpected, and that is that MTV's Sugar, kind of, let's say, a soap opera, Nigerian soap opera, was found in an experimental design to really lead to higher uptake of testing for HIV and so on, for targeting young people. That's quite remarkable, and I think it's not publicized enough. And the third area is about community mobilization, because if it's not taken up in a community, we have decision makers, we have community, we have individuals, I think the Ebola outbreak has been really an important lesson. And there's an interesting book that I recently reviewed. I can't remember the title, but it was by Paul Richards on Ebola. And it's about the people, he calls it the people science. And where he says that, okay, what's highlighted is the international response and Ebola treatment units and so on, and I think that was definitely necessary. But also it's what the kind of informal and formal type of communication that led to entire communities taking on the problem, sometimes with the help from outsiders, sometimes really what he calls this people science. And that's really good. Now, a final word I'd like to say is that, we, particularly people with my kind of background, we often think it's all about information and facts and so on. We know that that's not the case. And a good or a sad example is the increasing problem of refusal of vaccines and vaccine hesitancy. We had a well-publicized polio story, okay, and I think, UNICEF did a great job there, and others, and the Gates Foundation and so on. But there's a growing increase in vaccine hesitancy, and it's often among the most educated, the best informed people, and also it's because it's about something else. And our tendency is then to say, they don't know enough, and we give more information. I think that's a total waste of time. So we need to better understand what it's about. So that's why where the science also comes in, and that's highlighted in your paper. So I think it's, for me, we probably are coming back in an age where information, communication is going to be far more appreciated and should become an integral part in whatever we do in health, basically. Thank you.
Gaya, you work in the Health Emergencies program at the World Health Organization. How high up the planning process, the strategy, was communication in the Ebola outbreak? We'll use that as the example here.
I think the Ebola outbreak, unfortunately, lasted a long time. So I think the answer depends on when during the Ebola outbreak. The international health regulations, which all governments have signed up to, prioritize risk communication, which is what we basically call health communication in emergencies, as a core capacity. I mean, basically governments agreed they have to do certain things in order to have an informed public in order to deal with health emergencies. But of course, this became very important after SARS, when governments realized this was not just a health issue, that it affected their economies, travel, trade. So I think it went up quite high in the agenda, but the capacity required to do that, because this is very complex, did not match that. And I think there is agreement and in self-assessment by governments of how well they can communicate risk. They themselves acknowledge it wasn't enough.
And it wasn't far. I mean, okay, we're not, we all know that the response was slow, but in terms of communication, how was that quite an immediate thing? Like, we need, when we're sending people in, when we're looking at treatment centres, we also need to be looking at explaining to people what these treatment centres are and how it will help them to come in.
I think we did. I think even in WHO we had a network of 150 emergency communicators. But I think the scope of what communication needs to do was different before Ebola and then during Ebola. Communication in organizations, agencies, and governments tended to be public communication, media communication, telling people there was a disease, there was an outbreak. And that whole continuum to reaching the individual community engagement, the linkage was not strong enough, and it took a long time. And again, going back to your point, what is this about? It's not just about telling people, it's about understanding why they can or cannot take up the advice they're given. And it was primarily Ebola and many emergencies. They're biomedical approaches. We know about the virus. We know how to stop infection transmission. But we didn't, as a global community and at countries, we didn't understand the importance of social science, what I call socializing outbreak response, understanding why people will not take your advice. And it took a long time. Many agencies deployed anthropologists to try and understand, but it was not systematic. The pieces didn't fit together. So I think Ebola has absolutely transformed the way countries understand the power of communication. We also forget that people have a right to know in terms they understand, in the context they live in, according to their religion, according to their cultural belief. So it's not a favor we're doing to people. People have a right to know, and they are part of the solution. So community-owned response became something that we, even in WHO, talk much more seriously about. If you look at all of the reviews of the Ebola response, including to a lot of criticism at WHO for being too slow, not being coordinated enough, at the end of that is a narrative which says community-owned responses should be at the core of everything we do. In 1948, when WHO's constitution was written, it was written that the participation of an informed public is essential to achieving public health goals. But 70 years later, we're still struggling to see how that can be done. It's also because the world has changed. Our health communication is based on the past. Today, more than half of humanity live in cities. Urban epidemics are very different. And Ebola was an urban epidemic as well as a rural epidemic. Yellow fever recently is an urban epidemic. The dynamics, the scale, the complexity is very, very difficult for governments. So I think it's a mutual appreciation, mutual learning, but we really need to get ahead of the curve. In the new, under the IHR, there is a new initiative, joint external evaluations, where experts from many of our agencies and others go with governments to assess capacities. And risk communication and health communication in emergencies is really yielding some results. We're seeing where the gaps are.
It's interesting you talk about, people deserve to know, which of course they do, and be told in the right language and how important that is. I remember when we started reporting on the Ebola outbreak, we were using the term isolation centres, because that is what was being used very early on. So we were repeating that, and then Red Cross called me and said, they're treatment centres. There's one over there. Is there? Excellent. Dr. Fox, I want to come to you. You're at USAID. How far up their priority list is communication?
Thank you, Tulip, and thank you. First, I want to apologize for my voice. I've spent the last 3 days without being able to talk, and I can tell you how important communication is. I've been so frustrated. So I can talk, but you're going to have to listen to me like this. So there we go. I knew you were going to ask that question. And initially I was going to say not far enough, up the chain at USAID. But now I'm going to say we're getting there. I want to do this in a much more positive light. Over the last 5 years or so, I think USAID has really taken on the question of using communication more scientifically with more evidence and data and doing more real-time tracking of the impact on different behaviors of social and behavioral sciences. So I think we're really getting there. Partly it's shame and blame. I think when a program presents an initiative now within USAID and they say, we're going to do X, Y, or Z, there's going to be someone there who's going to say, and what are you doing about community? And what are you doing about communications? A case in point, I think, is the recent funding for Zika. Fully 1/3 of the funding that USAID has received for the Zika outbreak is going to communication and community. That's amazing. When Ebola started, we were sitting there knocking on the door saying, please, 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 you've got to listen to us. And they did eventually. But I think with Zika, it started right from the beginning. This is the lesson learned. So USAID has worked with many partners to make this field, first of all, more respectable, and second, to help it communicate better. I think like Peter says, he'd ask a question and he'd get an answer back, but he wouldn't know what people were saying. And that's true. We use lots of a cacophony of different terms and languages.
Acronyms.
So being, yeah.
Many acronyms.
Oh my goodness, the acronyms we've been using. So we got to get rid of those. We have to communicate really clearly, and I think that's what's happening. And I think the other thing that's changed at USAID is we're linking the communications programs much more closely to the health initiatives. So you start sitting around the table with your peers and focusing on the key behaviors or lack of behaviors that need to not, and I agree with Peter's, not to be changed, but it's the behaviors that are going to make an impact on different health initiatives. And you work with them and you say, great. So you've got drugs, right? You've got services, you're nice to people, but are they coming? Do they understand? So being able to have that dialogue across the scientific community has been really important to us.
You mentioned Zika. Zika is a very interesting one, isn't it? Because we are dealing in a whole world of unknowns. So in terms of communicating this, and I've found it as well with our reporting, when people are asking questions, we do a lot of kind of Facebook Lives and Twitter Lives where people ask us directly. Some of the advice is they're still figuring it out because, clearly for pregnant women, it's the advice is more obvious. But for men, they're now finding the virus in semen for longer. So you've now got this message. I mean, I'm not even sure what the latest advice is. Abstain or wear protection for 6 months after you've come back from a Zika hit country. I mean, how do you communicate unknowns?
You communicate them carefully, and you communicate them with as much data as you have. In Zika, and I was telling Tulip, I'd hoped she'd ask me that question because we were sitting around with a bunch of epidemiologists and bug people and talking about what are the behaviors that we want to talk about with Zika and how difficult is it going to be to get any change in a population level around those behaviors. Because, and the guys came back and they said, well, it takes a long time to change behavior and it's very difficult and we don't know quite what to say. And the women looked at each other and we said, a pregnant woman would take about 1 second to hear that her baby could be protected if she protected herself. It would take about 1 second to change a lifelong behavior. So you have to look at the populations and the audiences that you're working with. So with the message around Zika, and I know that you have a wonderful Zika app that I was looking at last night from the WHO. It's around protecting yourself, protecting the community. If you, it's not abstaining, but it's saying looking at putting off pregnancy if you can with methods that are available while the Zika sorts itself out and while there's more information at the community level. And that message goes very much to families and communities, very much to women. And as I said, it will take about 1 second for a woman who's sitting there in the first trimester to be told it's really important to put on DEET or whatever else is available. It will take about 1 second.
Let you rest your voice for a moment. Thank you.
Rest your voice.
Dr.
Yeah.
Obregon, you're at UNICEF, you're Chief for Communications Development. I mean, in all honesty, on the ground, how effective is it? How much is communication being implemented properly? And what are the sort of frustrations you come up against?
Well, thank you. Well, communication has been at the heart of UNICEF's work for several decades, going back to the child survival revolution and how communication was instrumental to mobilize communities, governments, partners to reduce the huge numbers of child deaths over the years. But even so, we also have realized that as we engage in addressing new issues, new public health challenges, the integration of lessons learned, of evidence, of data into regular programming is not as straightforward as we would like to see it. I think the report that Caroline has written captures some of those challenges very well. So from our perspective, our challenge is to ensure that governments, civil society organizations actually bring those lessons into the practice on the ground, especially to address some of the issues that have been raised in terms of making sure that communities are part of the response, that there is an ongoing dialogue with local communities to adapt, to adjust our strategies. So that we can be responsive to the local context. But in doing so, I think we face challenges in terms of the extent to which these, lessons, the evidence, the standards that we would like to see applied are regularly integrated into local systems. And I think that's one of the issues that we hope as an organization to bring to the forefront of the international development agenda. I also would like to mention that as an agency whose primary mandate is to advocate for the rights of children, then for us it's also extremely important to bring into that process young people, youth networks, children themselves, so that they can have a voice in that process. The Ebola response, for instance, also showed the key role that young people played in that process, in multiple facets, being part of community-based surveillance efforts, providing support to early warning, and being part of these dialogue and feedback mechanism to see what was working, what was not working in the context of the response. So I think that that level of engagement needs to be at the core of the work that we do moving forward. One last point that I'd like to make is that over the past years, and going back to one of the points that Elizabeth mentioned, we have made a lot of progress in terms of understanding what are the key elements that would make part of good communication, of good community engagement. And I must say that in this field, we have learned quite a bit over the last 3-4 decades. So one of the things that struck me in the discussions around Ebola was the fact that somehow the notion of engaging communities, bringing people to the center of the response was new. Perhaps what happened is that we actually didn't do that well. But I think that notion of people at the center of development and at the center of public health emergency response, I think it's something that we've seen for a long time. In the HIV, and Peter certainly can speak about this with a lot of authority, but in the HIV epidemic, that was a fundamental aspect of success over the years, bringing the affected people into the response. And I think that that's a key lesson that sometimes we don't apply equally across other public health emergencies. So rather than bringing that as a new element into what we do, I think it's just we need to recognize that that is a fundamental aspect of good communication. And the challenge is, how do we make sure that moving forward, it will continue to be at the heart of it.
And moving forward and embracing these strategies involving communication, you need evidence, don't you? I mean, we know that medicines make people better. We know that vaccines can prevent disease. What evidence is there, and I know that you've made a start on this on your paper, Caroline, but what evidence is there that communication works? Hard evidence. I don't know who'd like to take that. Perhaps, Dan, you could start.
I think, as some of the panellists have said, there is evidence. I did a meta-review when I was at Public Health England about it, having had lots of conversations with economists who were like, this is just the fluffy stuff, there isn't, it's not there, you guys don't get RCTs, etc., etc. And actually the evidence was a bit depressing, because when there were hundreds of papers that the systematic review turned up, but when you filtered those for outcomes and to a certain level, a standard, not even going for RCTs, although there were some in there, it was a handful. It was less than a dozen, I think, for the areas that we were looking at, which was so. I think it is there. I think communicators on the whole haven't built their programs to generate evidence. And
why do you think that is?
I think that's partly a sort of tradition and a mindset. I think, why else is it? I think the other reason is almost an ethical urgency. So people wanting to, the idea of building in variability to a response, for example, so that you can assess the levels of difference in response, feels kind of inappropriate at times, I think. Whereas you look at, say, the work of people like Esther Duflo on randomised control trials, and the difference that like a £5 bag of rice can make to uptake. That for me, that's a form of communication and it's a form of engagement that you need to build in and generate through. So I think there is evidence. I think it's patchy. I also think we haven't been brilliant at translating our evidence base for the kind of medical community or for the economist community. But when we start to do that and you start to engage, then you do get results.
Gaia, you had something you wanted to add there?
Yes, because WHO is one of the few UN agencies that's mandated to develop standards, and we have quite a strict way of looking at what evidence constitutes, what's robust enough, and how to translate that into policy, strategy, and so on. Because our member states will uptake this, and it has a lot of implications. And we embarked on an effort to develop the first evidence-based guideline for emergency risk communication, so making it even more difficult. And this is exactly what we found. It's patchy. Whenever I talk to partner agencies, everybody says, yes, there's evidence. But, and we've commissioned a lot of systematic reviews. And in WHO, we had a big battle when we started this, because again, the guideline development committee said, oh, well, no, I mean, you don't have, you can't quantify it. But over the last 18 months, the guideline review committee has actually developed a new process for qualitative data and mixed data. So I think we are making great progress. One of the reasons there isn't enough data is, as Dan said, we're not planning for it when we implement programs. Many programs are not. Many institutions that are on the grounds, NGOs, they're not funded to do this. Really, there isn't enough funding to do this. There isn't expertise to do it. But I see a coalition, a coming together of many agencies, bringing their evidence, telling us where things are. So I think there is a little bit of a movement, and I really hope that this accelerates very fast. The issue is a lot of the evidence is about contexts that have evolved now. So as I said, in urban epidemics, it's really very difficult. You may have longer term evidence about HIV programs, and I agree. But there's a lot of evolution and motion and change. And I think we really need the expertise, the advocacy, the money, the personnel to do this in a systematic way. But I think the work has absolutely started, and I can't agree more with your analysis about this. Evidence is what will make this professional. It will tell donors what interventions actually bring outcomes, not just outputs. And whatever we say, and I agree with Raphael, and we had people-centered work before, but I have to be honest, during the first few months of Ebola and many, many emergencies, every agency, including ones that are community-based, are just pushing messages. We're just telling people what to do. In Nigeria, UNICEF and the government and we were going knocking on 5,000 doors every day. It was an amazing operation. But when I asked people when they came back, what did you do? They said, oh, we taught them how to wash their hands. I said, well, what were their concerns? We didn't have time or the expertise to listen. So I think there are many gaps, but the fact that we acknowledge the gaps is a very, very big start.
Let's hear from Peter.
Yeah, thanks. Well, I just agree that the evidence is patchy. That's true. Why is it? I mean, as Dan said, partly is the culture in the community, but also heavily underfunded. I mean, because this is not cheap to demonstrate evidence in certainly in experimental or quasi-experimental design. The methodology is a challenge. Also, we shouldn't underestimate that. And then the standards are getting there. So I think there's good progress. At our school, we work a lot on HIV, but hand washing and so on. And Carl Curtis is here. I mean, it's really developed into a science that has demonstrated evidence. And I think, frankly, we should also look at particularly consumer businesses, because they're not asking for the ultimate randomized control trial results and all that, but they have quite a body of knowledge and evidence that is underpinning their business, and they're, and for them it's the bottom line that counts. And we've also ignored that, and even being very hostile. We can't deal with these people because that's bad, private sector. So I think we can learn from that, from these approaches as well.
I'd also like to get your perspective on the AIDS epidemic and what we're seeing now, how communication worked at that time. Clearly you were heavily involved, and you were saying before about it sort of going out the window a little bit and there being too much focus on the medical interventions. Just tell us about how you've seen that play out.
Yeah, in the early days, all there was, before there were antiretrovirals, the only thing was communication and condoms. That was the technology. And that had definitely an impact in the first place in high-income countries, in the gay community. I mean, spectacular impact, but also in other countries. And we tend to forget that. When you see when did the decline of new infections start, it was in the late 90s. Before, there were widespread antiretrovirals. So there's been real progress, but we're still now stuck with the 2 million new infections every year. For the last 5 years, there's not been a decline. And there's been a massive failure of prevention, basically. And I think there are a few reasons for that. One is that I think that the strategy is wrong, because it's been a combination of medical hubris, just the drugs will fix this problem, where it is about sex and behavior and drugs and what have you. And that's always easy. If we can give a few pills, we don't have to talk to people to listen, not to listen, and not to address power relations in sex and what have you, gender and so on. So what we need to do is to reboot the strategy, I think is one of the first things to do, and put more emphasis on so-called combination prevention, which must be tailored design or, to use the buzzword of the day, with a design system, system design and so on. And that means, as we heard, listening to people and that's very context specific. Something that is also biomedical people hate, because a drug works wherever you are. There can be some genes that make for some that it's not well absorbed or something, but in terms of behaviors, community mobilization, just like health systems, very context specific. So communication has to come back in the AIDS response in a big way, even for medical interventions, even for treatment adherence. I mean, that's all about behavior, but not just individual behavior. If we've learned something, and that is that there are structural interventions that are needed, that there is a context. We also need to rebrand AIDS. I think the whole rhetoric about the end of AIDS is there, 2030, has been extremely counterproductive. One, it is an illusion. It's not going to happen. So we shouldn't tell lies. But it was there because of, as I said, medical hubris. We've got the pill, we've got a mathematical models tell us that it's going to happen. And then for, to convince US Congress to continue to fund PEPFAR and so on, and so on. And so we need a soft landing of that, where, of course, you need to be aspirational. We want to eradicate poverty and gender inequality and so on. But setting a date to that for elimination, I think, is very, very, very risky. Look at polio elimination or eradication. I mean, enormous progress, but the last bits are so difficult, and that's a piece of cake compared to eliminating HIV. So we have to take this long-term vision, incorporate fully, communication in this again, and the community perspective, bring back perspective of people living with HIV, and then not forget that there are still many, many taboos in many countries about harm reduction for drug users. The one thing that's worse than sex is drugs when it comes to AIDS. How to deal with that. And there's a new wave of complacency. Just for those who are not from London, but in London, every single day, 5 gay men become infected with HIV. So it's not over. This is a city where there's huge tolerance for sexual diversity, access to treatment, lots of testing and all that. And we forget that it's about sex.
Caroline, what do you come up against when you go, I mean, it may not be you personally, but BBC Media Action go and ask for donations to deal with some of this, to do some of the communication on the ground? Is it often sort of seen as quite wishy-washy, or are people taking it seriously?
I think with some donors, it definitely still is seen as a very kind of fuzzy science, and in particular, I think the return on investment that you see from communication isn't clear. So I think again that's an area that we really need to focus on when it comes to evidence, is developing evidence around cost effectiveness and making it very clear to policymakers what they can expect to see for their investment, rather than just some wishy-washy return. I did want to say that it's great to see the leadership from the organisations on this panel when it comes to the role of communication in global health, but we can't take that for granted, and there really still is a shortage of money going around when it comes to funding for communication intervention. So yes, USAID, UNICEF, WHO do play a key role, but when we look at the amount of money that the Global Fund are allocating to communication, for instance, it's a tiny amount. $66 million of the $10 billion that they've approved for 2014 to 2019 is going to communication. That's shocking to me, and it suggests that perhaps the funding requests for communication work aren't coming through from national governments that are submitting their proposals to funding for the Global Fund. So something I think needs to be fixed there. Similarly, Gavi, only 1.2% of the funding that they've approved recently is allocated to demand creation work and social and behaviour change communication work more generally. So there is leadership within the field, but there are still many funders of global health work who aren't necessarily getting the message about the importance of communication. And so, again, we can't be complacent that the value of communication is really understood. And of course, that then is reflected in programmes. Peter's mentioned some of the communication deficits when it comes to HIV. There are also real issues, I think, when it comes to the use of communication for maternal and child survival. WHO recently have noted that that policymakers are still really underestimating the value of communication for maternal and child health, and that the use of social and behaviour interventions more broadly is really limited still in many contexts, and the role in national strategies is really weak in some cases. So yes, great leadership, but there's still a lot of advocacy work to be done with other major organisations, I think, and evidence plays a key part in that.
We want to get to the questions from the audience, but I will just ask each of you very quickly and just give me a succinct answer if you can. And Raphael, I'll start with you. What is the one thing that should happen now to make communication a higher priority in the global health community? If there's one thing that could be done, what do you think that could be?
Well, let me just very briefly say a word about something that Peter mentioned in terms of vaccines and immunization, and specifically on polio, for instance. In our experience, how just to reach that sort of last mile, how communication remains so critical to, for instance, build trust among communities that still are reluctant to vaccinate their children or are in hard-to-reach areas. We've done a lot of work in Pakistan and Afghanistan actually to understand what are the sources of mistrust, and then by engaging with those communities, identify ways of addressing some of those challenges. So just wanted to emphasize that point as well in terms of the work that we are doing with Gates and other partners. Now, I'll go back to some of the points that I mentioned earlier. I think despite all these challenges, I think we've learned a great deal in terms of the centrality of communication to advancing public health goals and more broadly development. We have made huge progress in terms of the science around communication, the evidence, even if it's patchy, but we are again making progress to generate more evidence. And I love to have a discussion about what kind of evidence, as Peter actually mentioned earlier. We also have made a lot of progress in identifying what are some of the critical standards that need to be part of any communication response. So I think if there's one thing that needs to happen is to bring together partners, donors, key stakeholders, and find a way to align this field to minimize the huge fragmentation that we find across the board, and somehow work with partners to make sure that those standards, those quality issues are part of of good communication and engagement of communities on the ground. And as you know, this afternoon we'll be having a conversation about this issue. But I think that's one aspect that would be extremely important to see happening. We've seen it in other sectors. We've seen it in WASH. We've seen it in HIV. We've seen it in education. They all faced similar challenges, and they had to come together as a community to actually define standards, align agendas, allocate resources more strategically, and I think the time has come for communication to do that as well.
Okay, thank you. Dr. Fox, we're cutting into our Q&A time in a minute.
Sure. Great question. What's the one thing? The one thing is country ownership. Until countries have the ability and they have the tools from WHO standards or from whatever. So when a donor comes in or anybody comes in and says, I'm going to do a health program, and the first question they ask is, where's the community? Where's the communication? Are you listening to what's being said in country? If this is not country-led and they make us change and say you've got to work with our communities and you've got to listen, it's not going to change. Because donors, we can do standards, we can do stuff, we can publish, but it has to be country-led.
Okay. Peter?
I was going to say same thing. I call it globalized communication. It's been too much dominated by a few people in the West. And so this ownership and this, and this other cultural perspective, number one. Two, I'm in academia now, so develop the evidence-based, strengthening that, gone away. And three, as I mentioned, I think bring in the business community, particularly from consumer companies.
I totally agree. Everything has to happen at the country level, but with the caveat, it should also include the local level, and that's a lesson we've learned. The advocacy has to come from there, the demand has to come from there, and countries, and we have to put money, political support, as well as expertise to help countries develop the strategies, not just for developing plans, but for networking amongst their stakeholders. The Red Cross movement has 17 million volunteers from communities. I mean, that's a great resource governments have to use. There are many NGOs that are present in tens of thousands in each country. I also think that countries should be encouraged to take that process further and to operationalize across government. When an emergency happens, we plan with the health sector, but prime ministers and presidents take over communication and risk communication. So this whole of government approach has to be supported, but really linking the local to the national. And the demand, as Elizabeth and others have said, has to be demand made by countries.
Thank you. I'd just like to make a plea for empathy, actually. So one of the things I notice amongst the global health community is we are as afflicted by the curse of knowledge as any profession. And we don't apply our own standards to the way we behave. Our ethos is about engaging millions of people in matters of life and death. And then we casually use language like isolation ward, or we did some research on antimicrobial resistance, which is an incredibly important issue. And when you do research with our audience, they don't understand what you mean. The name doesn't make any sense. We spent less effort thinking about how to name antimicrobial resistance than Nestle would put into naming a chocolate bar. And I don't think that, I think a lot of the issues that we come across are around that. So that George Bernard Shaw quote about the biggest problem in communication is the illusion that it's taken place.
Caroline.
I also wanted to make the point about country ownership, so thank you, Elizabeth. But now that that's been made, I do want to come back to the issue of evidence. And I think we've touched on this, but a real barrier, I think, there are these ongoing debates about what constitutes evidence and what counts. And I wanted to make the point that WHO, led by their Department for Maternal, Child and Neonatal Health, are doing some really important work with GRADE to reevaluate evidence standards in this area, recognising that the standards currently being used don't really work for complex social and behavioural interventions and interventions at community level. And I think that that work is really progressing well. And if we can come together as a communication and public health community and finally agree what counts, we actually have a chance then to fill the gaps that exist in the evidence base, rather than endlessly argue about whether we need an RCT or whether some other form of evidence counts. And I think we're really beginning to make progress there. So we need to embrace that work being done by WHO and expand that, I think, to all areas of public health. And finally, I think ultimately it would be really powerful if all of this work on evidence could come together in the development of some kind of investment frameworks for social and behaviour change communication. I think those kind of published frameworks have been really useful in the advocacy efforts of the women and children's health community, because they enable you to demonstrate the need for investment, but also then to propose really specific packages of effective investments, and also to demonstrate the return on investment that you're likely to see as a funder. And I think if we were able to take that kind of action as a field, that would be a great step in accelerating the role that communication can play in improving health. So that's a plea from me for that work.
Okay, well, thank you very much. We'll take some questions from the floor as well. And those who are still with us on YouTube, please do use, I'm going to get my phone out and get on Twitter now, the hashtag #DiscussHealth. I'll keep looking at this, so if you do send in some questions, we'll be able to put it to the panel here as well. So yes, wonderfully put by our many eminent experts in the field, and it's nice to hear some heart there as well from all of you, because it's easy, I think, to, you know, it's a scientific problem or it's a problem that needs a strategy, but in the end, of course, it does all come down to people, and all of us on this panel and probably in this room have seen the suffering these outbreaks, or, you know, the non-communicable diseases as well, cause in people's lives. And really just by discussing and talking and having the information you need and being involved yourself as the community in the response can make a huge difference, not only to the disease or whatever you're dealing with, but also to how you feel. So we'll hand over to you. Who would like to be first? This lady here. Thank you.
Hi, good morning. Val Curtis, London School of Hygiene and Tropical Medicine, as Peter said, worked mostly on hand washing, but hand washing is an interesting topic because the intervention is communications. And I suppose over the last 10, 15 years, we've been trying to build a science of behaviour change around hand washing. And I guess I was saying 15 years ago, we don't have enough points on the graph. Well, now we have a lot more points on the graph. We're able to have a bit of a cloud. We're able to say, okay, this sort of intervention looks like it's producing that amount of that amount of result. We're beginning to see patterns emerge. We're still a very long way from a proper evidence-based professional science of communications stroke behaviour change. One of the issues we could debate is what's the difference between communications and behaviour change, and that's probably part of something that we should be communicating about. Anyway, part of the problem, as you say, not enough investment. Part of it is, but how do you do an RCT of a media-based intervention, for example? Hugely difficult to do. We are beginning to find the as I say, get the pieces together that are beginning to say it's not just about getting enough messages out to enough people. It's not about messages, it's about what is in that message. What is the lever that is actually going to make it something that the person who is hearing it is going to go, that's what I want to do tomorrow. I'm going to start doing this. They're going to change their optimal policy of what they would normally be doing into doing something different. And we still haven't fully grabbed that and figured out what that magic dust is inside the communications that is actually going to pull the levers that are going to change it. And marketers are very good at this. It's still not a science in marketing. There's a lot of fairy dust there too, but we can learn a lot, as Peter says. But the one big thing that I wanted to suggest was that if you are, as I traipse around a lot of countries, the first thing I ask to do is to go and see their health promotion unit in the Ministry of Health, usually still called Health Education Unit. And, you know, I kind of feel I want to wash myself down afterwards because of the dust in those rooms. You know, they say, I ask them what they're doing about Ebola or about hand washing, and they pull off something from a top shelf, which is a CD. We made this CD, but that CD is not in no household has ever seen that CD. Here's our posters, all rolled up, covered in dust. This is what we do. Now, I plead to those who have investment to spend on in health communications that those units are where we should be building the skills. And this new profession, and then the question keeps coming back to me, can you suggest more professionals who can help us do this? And we're really short of professionals who can help do this. So again, everything you've said points to the fact that we don't have a proper discipline of communications in global health, that when we build evidence, we will grow that, but we need to grow the professionals and we need to grow the institutions that can deliver that.
So what would you like to ask? Sorry, I mean, all very good points. My point is, to those who are funding, what's your plan to get into those, to turn those government units into nudge units? Why have we got nudge units, but there aren't nudge units throughout all the countries that need them most? Okay, let's hear from our funders then on that. Oh, sorry. Oh, I see. Okay, yeah, there we go.
Actually, Val, thank you for your speech. It's lots of good points. I actually just spent last month in India, which has just introduced a nudge unit because they've been busy handing out toilets to everyone and no one uses them. Good question. What's going to make that happen? I think this is got back to the country-led question. Donors can do so much. They can ask the right questions. They can also serve by example by our own social and behavioral science approaches. But the ability of countries to actually focus on behavior and not just on investment in stuff has to come from people saying, where's the accountability and where is the use of funds actually optimal? Because only so much can go to a latrine without people in it.
Well.
It's a great example.
Yes, thank you. Thank you, Val, also for bringing that up, because it really triggers an important issue for us in terms of our focus on strengthening local capacities. We just went through a global evaluation of the work that we do on C4D, and Mary Myers, who's here, was one of the external evaluators. And that issue was highlighted as one of the major challenges that we face in terms of making progress in a number of these areas. So for just in terms of concrete examples in India, and we'll stay in India, we have been working with 9 state governments, particularly those that have the worst social indicators, to strengthen those local capacities. And they have established social and behavior change communication cells that essentially are meant to precisely bring a lot of these elements that we are discussing as part of the public health system response. And I think that's the point that I wanted to raise, that we often talk about communication as an intervention, as a strategy, as an issue, but rarely do we talk about communication in global health as a critical component of the public health system. And until we make that shift, it's going to be really difficult to make the kinds of investments that we are talking about and see the kind of change that we are talking about, especially when it comes to local ownership and local implementation.
Thank you. We'll take 2 questions together so we can get through as many as we can. This gentleman in the front, followed by this lady in the second row. If you could just introduce yourself as well, please.
Thank you. Keith McAdam. I'm a trustee of BBC Media Action. I'd like to comment on style of communication and how that affects the outcome. So at the beginning of the AIDS epidemic, we had tombstones falling in England and humour from Denmark. I wonder which was more effective. In the Ebola epidemic in West Africa, we had the focus on death as the outcome that was inevitable, and it made people not want to go into these Ebola treatment units. So these were styles that were chosen presumably by people who knew about communication, but had a deleterious effect. And I wondered to what extent academic departments have actually grown up around communication. Even at the London School, I would ask whether that is a priority. And presumably, the funding agencies aren't supporting communication, or it would be more of a presence in academic institutions. So I guess the question is, how does an organization like Media Action collaborate with academic institutions most effectively as a professional communication organization to help the many aspects of communication that occur in virtually every randomized clinical trial that occurs in lower income countries? So where's this going to start? Is it with the funding agencies? Is it with the providers of communication? Or is it at country level where there's such a diverse communication with social media, particularly affecting from the diaspora outside the country, local radio, great diversity, each trying to vie with each other for prominence, and it's not quite clear where the push and pull of improved communication is going to come from.
Okay, thank you. And Keith, if you could, we'll perhaps let Peter answer that one in a moment. Let's just get the second question quickly from this lady.
Hi, I'm Annie Wilkinson. I work at the Institute of Development Studies. I worked actually on the Ebola epidemic. There's an anthropology platform that was kind of aiming to integrate social science and academic expertise into the response. So it's kind of relevant. But my question, and so it's very good to hear all this kind of discussion of communities and putting them at the centre. But my question is about how do we make sure that we know we're working with the relevant communities and structures within them, and how do we make sure that we're not imposing our own ideas of what those relevant communities are when we kind of implement communication strategies. So, you know, in Ebola, lots of work was done at the village or ward level, but actually maybe there were political or social structures beyond and within these units which were more relevant and more or less trusted. And then, so how do we make sure that we're being sensitive to that variation, which even between Sierra Leone and Guinea was historically, very different?
Thank you. So let's start with Keith's question around academia, looking into communications. Is there a proper commitment to that?
Well, as you know very well, Keith, no money, no mission in academia. And so the key is that we have to convince those who fund research that this is proper science. And that has been a big issue. And even if there are calls, I've been on funding panels, and the first, proposals that often are just ignored or dropped off is when they think it's too soft and wishy-washy. Somebody used that term. Yes, Dan was that. And I think that's where we need to have a concerted effort towards that community, at least in this country. That's a big issue. I think the Ebola epidemic was a kind of a turning point. It's a bit ironic that you need something that's so atypical to discover, quote unquote, that communication actually is quite important. As you mentioned the anthropology platform and so on. This is, has brought also investigators together, because the field is quite balkanized, and then it's only, let's say, united we are strong, to use that term. So I think it's not a matter of that for us whether it's a priority or not, and it is a lot of the research is very investigator driven, and I think now what we have to do is to make sure that the message is there, and I think that's why this meeting is important, the report, the fact that standards are being made and that we develop that and turn that into a science. You can go back to so-called implementation science, a term that's popular now in the US. That was also an approach that was not popular with funders, and now also that was driven by HIV. Large-scale programs, lots of money, not really knowing what the return on the investment was to, as you said, Caroline. So that's I'm quite optimistic that it is moving, but it is a matter now of convincing in the first place those who are on the research funding side, like the Wellcome Trust.
Just very quickly, and then I'm going to do a couple of tweets before we go to Ali's.
So the Wellcome Trust does fund some work in hand washing and some work in RCTs around mass media interventions. But we're a response, a lot of our schemes are response mode, and I think we ask that question about where's the science. So it needs, and I think it's not framed in it, so it is getting through sometimes, but it could be getting through more. And I think there's something about the insecurity of the profession potentially, and that it tries to rebrand itself every few years as social marketing, or and Caroline's report, or behaviour change, or all those sorts of things. And in doing so, it's very different to other areas. Epidemiologists don't have that issue, although they will. So I think something about
figuring out what it is you're trying to do and sticking to that
and having the confidence, because the evidence is there. We're not, you're not flogging a dead horse. Yes. It's not special pleading. It's important. I think people buy that. Practitioners buy that. Leading experts buy that. You just need something about the way the profession's working that can change.
Guy, I'll come to you just on Ali's question in a minute. I just wanted some people are getting involved online as well, which is great. Please keep doing that. #DiscussHealth. We've just had a couple more come in. Okay, Joanna Blakely, programmers haven't built their communication programs to generate evidence. It's a problem of mindset. Another one's just come in. Shouldn't global health actors learn much more from the private marketing sector, which you've raised, to improve communications? Let's get an answer to Ali's question, which is around communication teams going onto the ground. Are they speaking to the right people? Are they tapping into the right expertise? And I mean, we saw this ourselves as well when we were out on the ground. Is there a perception of, and is it indeed happening, that you are imposing your own values? I mean, I remember very early on, some people were saying to me, they're burying our loved ones in black plastic instead of white. And when they changed it to white, it made a big difference. So what's your perspective on that?
And with the previous question as well, absolutely, Ebola is an outlier that has a lot to teach us. So that's the first thing. Anthropologists and networks of anthropologists and sociologists were on the ground. They found it very difficult to be, the element of identification was often missing. Language, look, age. In many countries in Africa, I found it myself as an advantage. I was not white, I'm old, I have children. I'm a doctor, so identification was also an issue with many experts who were sent out. The issue with Ebola is, it was so frightened, it was health communication on drugs. People were frightened for themselves. There was a militarized, a more military response than a health response. People who were in charge of health communication, health promotion, were at the bottom of the food chain. And in this situation, the first posters obviously said, Ebola kills, which is true. Ebola does kill. But the issue was one of operationalization, and it refers to both questions. Anthropologists, sociologists were not interacting enough with response teams so that we could learn real time how we should calibrate our response. And one of the things particularly WHO is doing is bringing together a new initiative, bringing responders and sociologists, anthropologists together so that they work together before emergencies, so they at least know what information can be shared that will improve our response real time. This is not about academic peer-reviewed findings, this is real time. And I understand, I agree, no money, no operation, but operations have to include this aspect, and it should be sufficiently planned that it is at the center of the response. For Zika, it was the first time that there was substantial funding and a desk for risk communication. This has never happened before. So I think all of these things are true, but the flexibility to move very fast, to talk amongst different communities. Epidemiologists don't know how to talk to communicators, don't know how to talk to sociologists. So we have to do that work now and rely much more on community-based organizations that are still there. So you can get first-hand information.
Okay, thank you. Shall we hear from this lady at the front, please? Thank you.
Hi, Sophia Wilkinson, BBC Media Action. I just wanted to ask you, Gaya, when you're talking about the first responders, bringing sociologists, anthropologists together with those first responders and with the communicators, are you explicitly including the very local media as part of those responders? Because we kind of slightly seem to be talking about communicators in a slightly wishy-washy way, and I just wanted to ensure that the local media are included as part of those responders.
If I said yes, it wouldn't be correct at scale. If I said yes for certain situation, it would be correct. In Ebola and in many outbreaks in low-income countries, we know that community radio and local journalists are not necessarily trusted with messages, but a forum for people to participate. I think, we have to go from message-based communication to skills and strategies to engage and participate. That gives us flexibility to change the messages. I think this is one skill. We ourselves work with journalists beforehand, and training journalists, and I know the mandate is very similar. We found that it was important to train journalists, give them basic knowledge on the science as it was evolving without giving them news. And this is very difficult for WHO because we don't like to speak unless we know everything. But we have, and in Zika we did this. We sent out to 9,000 local journalists right at the beginning what we knew, send them the app we developed so that they could be updated. So the basic science is there and they can then start having conversations. Are they systematically involved? No, absolutely not. Do we want that to happen? Yes.
How much are you using social media in UNICEF, for example? Because in certainly my experience in Sierra Leone, everyone's on WhatsApp. In fact, Media Action had their own WhatsApp service, didn't they? That is how people communicate. They don't go to the UNICEF or WHO website. They don't necessarily listen to the radio, watch TV, but they are on their phones.
Well, we are using social media and new media in multiple ways. In the context of the Ebola response, one of the platforms that we brought into the set of tools that we used was a tool known as U-Report, which has been implemented in several countries. Started in Uganda, and it's essentially an SMS-based platform that facilitates two-way communication with local communities, especially young people. So we set up U-Report platforms in Sierra Leone, in Liberia, which supported a number of these issues just to facilitate that type of engagement. And that's just an example of how we did it in a disease outbreak context. We've done it also in Zika. We'd set up U-Report platforms in Mexico, in Brazil, and other countries. Now, I just want to say also that that for us it's also important, as I said earlier, engage young people and local communities in a process where they can become more empowered, they can be more active in holding providers and duty bearers accountable for services, for inclusion, for quality. And I think that's a fundamental issue that we also need to bring into the picture, and that is how do we look not only at the particular problem that we are dealing with, but how do we facilitate, as it was said earlier, more sort of a people-centered process where by empowering communities, citizens, by enabling an environment where they can take action, they can actually advance not only public health outcomes, but broadly speaking, other development outcomes. If we think about the lessons from HIV, for instance, I mean, the implications of the level of mobilization and engagement of local organizations and communities had an impact not only on HIV, but broadly speaking in other health issues. So I think we need to look at these equations from both ends. So then the use of social media and other platforms that facilitate that type of engagement is absolutely crucial for us.
Okay. Take a couple more questions from the floor. This lady here, please, followed by this lady here.
Great. Thank you. Jane Hobson from the Department for International Development. Thank you for a really, really great panel, and I find this really encouraging. I think the debate on this subject has moved on enormously in the last few years. I'm not so sure that the practice on the ground has. I think there's quite a long way to go still, but I am nonetheless encouraged. I wanted to quickly mention one other use of communications that we've deployed, which is around this idea of breaking the silence, which was very much a deliberate part of our work on FGM over the last few years, where DFID's communications department had a proactive communication strategy to complement the programming and the other work that we were doing. My question is around the challenge that some of us face as donors, and picking up on some of the points that particularly Caroline made. I work on family planning at the moment mainly, which is an area where a lot of people are much more confident talking about commodities, supply chains and so on than they are about this kind of thing. It is also about sex as well, which often gets forgotten in some of the conversations, but it's often a difficult area. It's also a world where showing the results you're going to deliver and the value for money are extremely important, as we all know now. So my question comes out of that and the need to get to the real specifics. And I'm starting to wonder if we're making a lot of assumptions about what we mean by communications, and perhaps we've all got a slightly different thing in mind. And I'm still finding it a little bit slippery in this conversation. And maybe the answer's in Caroline's paper, I'm hoping so. But I'd really welcome some comments from the panel about what the real sort of hard specifics are. What are the combinations of actual interventions that we think work, in what combinations? Yes, it's context specific, but in that world of demonstrating results and value for money, what are we really getting at here? Thank you.
That's a great question, and perhaps I think it would be useful to just get a very brief from each person, and if your definition of communication overlaps with somebody else, maybe choose another one. Gaya, you have the mics. Perhaps we just start with you. Define communication, or the most. Obviously, it's multifaceted, but the most important part for you.
I think it's picking the best strategies that allow us to understand people's situations and perceptions. And I'm not very dogmatic. I see at least 20 strategies, from whether it's health education, community engagement, media communication, social media. When we train people, we train them to pick the best mix, but the best mix that helps us understand people's context, that identifies the behavior and helps people, empowers people to get that behavior. I know that must be a very frustrating answer for you, but really my point is this: we have to build capacity for people in this field to analyze and to pick their own strategies. I do agree with Suzanne, though, that we may be able to articulate some best buys in certain types of situations, which has helped donors and policymakers buy onto this. So I've frustrated the audience, but okay, I'll stop now.
But talking to affected communities directly.
The whole spectrum, from speaking and listening and understanding the communities all the way to the policy level. So risk communication includes policy communication, political communication, media communication, social media, behavioral change communication, health promotion. So I frustrated you some more. DFID is never going to fund me, I know.
Dan, if you
Please change your mind, all right?
Yeah, you've got to be careful about that, haven't you? If we could just ask a few more questions, we'll be able to get definition. But one of the things we used a lot in tobacco control, which was almost this idea of integration. So that would be my plea. You know, there's a kind of marketing mix which includes the product and it includes the price. And there's a commercial sector has come up a few times today, and they are quite straightforward about it. And so for me, we kind of say, well, what's the objective, and where do the skills and tools that we have at our disposal, where can they make a difference, and where can't they? Importantly, not trying to lever your way into everything. Sometimes very straightforward informational tools can work. So I think for me, that's where we start with the objective, and we try and be integrated with the wider program and all of the tools at the disposal, and that's where communications works.
I'm not an expert in this whatsoever. I've been a funder and a client, but anyway, I would say 3 words: listen, understand, and integrate.
Okay, very good. Dr. Fox.
Okay, so it's a good question, and I would start with saying you also have to be very conscious of the fact that there are places where communication doesn't work, where it's not communication, where you've got a problem that's not a cognitive problem, it's not an attitude problem. It's something that's very much connected to context or to structures. And I think that's been one of our sins, I guess, as communicators, is we've thought it will work for everything, and it doesn't. And so as funders, being able to say, no, actually, latrine use, it's a matter of location, for example, or it's a matter of style. It's not a communication problem. And we've overreached in some cases, and that's complicated our evidence. So I think as funders at USAID, we go back and we say, wait a minute, identify where in this is there a communication issue, which then you get all the tools that are out there and you use them. But where is the communication issue? And focus on that and then use the right tool. But discard those that are not communication issues.
Okay.
Yes, thank you. I guess that's a very good question. We've been thinking a lot about it. And in our most recent thinking, I guess my answer would be it's a combination of what Peter said in terms of key principles that should be part of the work that we do in communication. But then in terms of the decisions that have been made to put together a communication strategy or support our partners in putting strategies together, we are encouraging our teams to look at 3 ways of making those decisions. One is, what does the evidence tell us? Where do we have evidence of impact of interventions that actually work? And we've done some reviews, and we know, for instance, that mother support groups, for instance, actually are very effective to facilitate certain type of changes. So certainly, if the issue is relevant, then why don't we use the evidence that we have and we bring in those elements into the response? The second is, what does the data tell us about the local context and what may work in those contexts? And that's very much, as been said, context specific. And the third one is to, in line with the notion of innovation and promising interventions, then try to be explore new ways of engaging with local communities or using communication to facilitate change. And then based on some of those analyses, then you will come up with the kind of mix that may actually drive results. You mentioned FGM, and we are working now with our colleagues in child protection to look at some of these issues as part of the joint UNFPA-UNICEF program. And that's exactly the kind of thinking that we're trying to bring in terms of how do we actually find the best mix that actually makes sense to the local context. So I know it's not a straightforward answer, and I think that's the challenge when it comes to communication, that you cannot have a one-size-fits-all kind of approach, that it has to be driven by the local realities.
Yeah, there are no simple answers with this question, clearly, but it's a very good one. Caroline, what would, from your perspective?
I think people have made the points that I wanted to make, that context is critical, understanding what the most important drivers of change are likely to be are critical, and all of those things combined make it clear that there isn't one off-the-shelf solution, communication solution that's going to work for any particular problem. But I do think that we have made progress in the last couple of years, that USAID and UNICEF did some work on mapping the evidence base around what works for behaviour change for child survival, and particularly on family planning. I do feel that the evidence base started suggesting packages of best buys. So we do have clues about interventions that have worked in numerous contexts. So I think there was a focus on the importance of schools-based sex education, the importance of mothers groups. So we have to be designing bespoke communication solutions for every context in which we're working, but we don't do that blindly without reference to evidence that tells us about what's proved most likely to work in other contexts.
Thank you, Caroline. We'll come to you in just one moment. I just wanted to read a couple more messages that are coming on Twitter with the hashtag #DiscussHealth. Genevieve Hutchinson, thank you for joining us. She's been in touch saying communication in health is about listening and discussing, not messaging. I think she was quoting you there, Gaya. Joanna Blakely's been in touch again. We often forget that many of these global health problems are really about sex. Dry information campaigns are not the answer. Good point. Val Curtis, again, she's actually quoting you, Dan. We put less effort into naming antimicrobial resistance than Nestle would into naming a chocolate bar. I'm sorry if my pronunciation isn't great here. Abosedi Olawai. We can keep working on the science without affecting the level and amount of work we do in communication for development. So it's not one or the other, it's both. Yes, exactly. Let's hear from the lady at the back. You could just say your name, where you're from as well.
So I'm Clara Strom. I work for Development Media International, and we've actually set ourselves the challenge to run an RCT and express outcomes in DALIs, and it wasn't an easy journey, but I think what we've discovered, and Caroline has sort of alluded to this, is that we've gone through this whole process of answering the question about how mass media can change behaviours relating to child survival, but as we look at new topic areas, we find that we get faced with similar questions. Can mass media or can a communication intervention make a difference here? Can we change those behaviours? What are the best channels? What are the best formats? What are the best ways of reaching our audiences? And I think something that I wanted to put to the panel is a question around what are the main questions that we need to answer to then sort of be prepared to respond quickly or to take an intervention to scale. What are the gaps that are still existing that this sector needs to fill? So instead of looking at one topic or one intervention or one particular area, what can we find out about mass media or other communication interventions that would help us to then say, right, you know, if we want to reach young audiences in Kinshasa, we know that Facebook is a good channel, but the main audience that we are going to reach is 25 to 34 years old, so we're not going to reach adolescents. We need to use X and Y channels. We know that, you know, this particular approach is effective for changing episodic behaviors versus, like Val has said, sort of hand washing, which is a very, very difficult repeated behavior. So I guess relating to what Caroline said, what do you think are the 2 or 3 main questions that we need to address, and how can this help us be prepared to then respond quickly, because we know that certain elements of a campaign design and the implementation are effective?
Few questions that I would ask is really, what do we know about the context, perceptions, beliefs of that group of people we're trying to reach and change a particular behavior? Who is trusted as an interlocutor for these messages? Who are the people we should be talking to and who should take the message? And this includes trusted and preferred channels and delivery systems. And I would say, what sort of analysis do we have of the behavioral factors that are different between people who will do or take up the behavior and those who don't do? So I think that bringing trusted, preferred, an analysis of that is very, very important. And of course, then you look at what capacities are there, who is there, what can we do in this time with the resources we have.
Okay. Elizabeth, have you got anything to add?
I would just add the negative. What's stopping it? Because you can look at trust and you can look at how to reach people, but why is it not happening? And we often don't ask that question.
Okay. We've just got a couple of minutes left, so it would be nice to hear any sort of roundup thoughts from the panel. I guess that question, why is it not happening, we've addressed a little bit. I mean, where do we go from here, Peter?
I think that we need to really have a bring the community together, what you're doing. I mean, I think this is key, because the message is not out there in the, let's say, the global health, how to say, the establishment, put it that way. that communication, that we can't reach our goals without. And also, recognizing that, as Elizabeth said, there are issues where it's not just communication, that's for sure. That's one thing. So that, I think, is really going to be very important. Bring it together, bring the science in there also at a certain, but define it. Not have. It's always important not let others define your space. Define it yourself. But if you don't do it, or if, what I was confronted with when I was in UNAIDS, and you have 5 different people in this field and coming to say, don't listen to X because I'm right, and so on, that doesn't work. And it's counterproductive. And then on one more detailed comment that I'd like to make is that we should not only think in terms of individual behaviors. It's also about communities, it's about structures, it's about the environment, the context, and thinking also how one can have impact on that. And that's even more complex to define. But if we only think that it depends on individual behavior, then I think we're going to fail. And tell a young woman in KwaZulu-Natal about, that it's her only responsibility and her only one to have safe sex and not to have sex and so on, in a context that is absolutely not conducive to it, we are missing the point. But that's a more detailed comment.
Okay, well, we've got some time afterwards to discuss. I think a few of the panellists are sticking around. Dan, do you want to have any finishing comments here? We've probably got about a minute.
Just a couple from me. One of which I think this conversation has been great fun and really reinforced to me that one of the glorious things about communications is that it's no respecter of boundaries, so it kind of cuts across everything. I think that's one of the issues that we have in terms of interacting with other disciplines. And the other thing was, I do think that there's a case that needs to be made by the community for more investment. I was struck when we were looking at childhood obesity, preventing childhood obesity in the UK, and we looked at how much are we spending on this across the 4 governments, and we were spending the same on communications that Quorn, was spending on promoting a variant of Quorn mints. So we're just not there. Like orders of magnitude, we're just not there, and we need to make that case.
Okay, we've got 1 minute each to.
Okay, 1 minute. Going to your comment about having enough funds and things like that, you can have all the funds in the world, you can have lots of technicians, you can have great pollers, and you can get it wrong. The stakes are very high. Witness recent elections in different countries. You can have the best communicators, and if you don't understand the public and the context, your message is wrong.
Thank you.
Before Caroline wants to say something.
I can make my final point next if you like.
Why don't I do it and then you wrap up? Okay. I thought you wanted to go first. Sorry. No, I just wanted to say that obviously a lot of the focus of our conversation has been on disease outbreaks and Ebola, obviously, as that kind of a turning point for the field. But certainly, as Dan said, there are a lot of issues where in global health where communication will remain absolutely critical. You mentioned NCDs, or non-communicable diseases, an area that we know in many countries is already has epidemic characteristics, especially around obesity and other issues. And again, various ways of engaging with communities and communicating will be extremely critical. And so the scale of the work that we need to do in terms of bringing communication to the center of public health systems is absolutely important, with the focus on precisely country ownership. One of the things that I worked for WHO for a few years as well, for the regional office in the Americas, and one of the things that I always talk about is the fact that when it comes to the risk communication capacity within the international health regulations, that's the only sort of binding communication-related component in any public health framework. So I think we need to expand somehow that type of accountability that various stakeholders have when it comes to strong evidence-based communication.
Thank you.
I just wanted to end on the point about building local ownership, and while recognising that that's everybody's job, everybody's role, I really wanted to sort of make a plea for the donors that fund our work to enable us to have a role. We've seen some great results at Media Action where we've partnered as peers with ministries of health and helped them build strong communication capacity, but too often that type of work's neglected in the types of projects that we have funded. I think partly because there's this tension between wanting to deliver quick wins when it comes to behaviour change versus supporting the building of that long-term capacity, and it's a frustrating business, staffing levels change, and often that work doesn't sit well alongside short-term behaviour change goals. So a plea really for more funding from donors for that kind of work, and more insistence that we build that into the heart of our communication projects, rather than letting us get away with just flying off and developing our own communication interventions without really integrating them into the local systems with which we're working.
Thank you. Finally, Gaya.
No one gets up in the morning and says, I don't want an NCD, or I don't want Ebola, or I don't want to have an unwanted pregnancy. I am one of those people on whom health communication doesn't work. I am much heavier than I want to be. I'm verging on obese, I'm overweight. And it's not for lack of education. Yeah. So I think communication is not about communication. It's about how we understand, interact, convince, support, empower people to make informed choices. And nowhere can we force people to do anything. It is about informed decisions to protect yourself and those people you love on a chronic disease, on a health condition, or an epidemic. So I think if we keep the end in mind, we are clever enough as a community to get there. We have come of age, but we need to grow up fast. And that includes working together, sharing, coming up with a business case, and really not just asking donors, but convincing them that without this, none of the development or emergency goals we have will come to fruition, and people will suffer. So it's not about what we do, it's about how people's lives can be made better.
Thank you, Gaya. Thank you very much. Let's hear now from James Dean, who's the Director of Policy and Learning at BBC Media Action, who can just wrap up for us this morning.
So first of all, I just wanted to thank everyone on the panel. It's been a fantastic conversation. We decided to do this policy briefing and to do this panel really to throw down a set of challenges. So just in sort of 60 seconds, there was a challenge that we wanted to throw down to organisations like ourselves, to the communication community, and it's all come out in this panel. We need to be clearer. The evidence needs to be much more compelling. The sector needs to be more professional, more consistent in how it describes itself and how it acts. But I think it's true that an awful lot of that is happening, and I think a huge amount of progress has happened on that over the last 3, 4, 5 years, especially thanks to people like Elizabeth and Raphael, who've been investing in the evidence reviews around this, World Health Organization, who's been really leading the way on things like the Evidence Standards Review. I want to pay tribute to Susan Kren, who's in the room, who's the director of Johns Hopkins School of Communication Programming, who led the way in organizing a major summit, major meeting, conferences earlier this year, precisely to address these kinds of challenges. So I think a lot is happening in the communication field. A lot more needs to happen. But the second challenge really is to what Peter calls a public health establishment. And I think there has been, this is a situation where just as in communication, knowledge is not enough. We have found that the kinds of arguments presented in this briefing have not been enough. Because there are, understanding this, accepting the arguments, there are a whole set of obstacles, cultural obstacles, of social obstacles, of political obstacles, financial obstacles. There's even stigma. It is not, it's fuzzy, it's unprofessional, we're not clear about impact and so on. And I think we need to get beyond that finally, because these kinds of discussions have been going on for quite some time now. And it really is about engaging the public health establishment with a conversation which doesn't just end with saying, well, we're not convinced by the evidence, but said, okay, help us then get, what do you need to be convinced? But not being convinced by the evidence doesn't make the problem go away. There was a fundamental set of issues here where people's lives are being lost, often in their millions, because we haven't got ways of engaging people in what I would describe in communication, getting inside people's heads to feel that people can do better, to feel that they can take control of an issue, that they have the confidence, the efficacy to do something about the issue that is confronting them, about acting differently, about thinking differently, both in terms of individuals and in terms of communities. And I do think that this is a huge missing link when it comes to public health strategies. And a lot of this has been trying to unstick a conversation. And I think the conversation is stuck not just because of things like lack of evidence, but because of cultural divides, different mindsets at work. We're coming at it at different points of view. We have to meet somewhere in the middle, and we need to find a terrain, a common vocabulary, a common set of challenges, but make it all of our to understand the urgency and the importance of really actually taking moves forward collectively rather than in different siloed communities, which has, I think, tended to be the point of the past. To me, this conversation has been fantastic in enabling us to do that, and I think it's a huge step forward, and I think it's been brilliant, so thank you very much. I also want to thank the Gates Foundation for hosting this. Miguel Castro, unfortunately, who was absolutely instrumental in hosting this, his daughter's sick this morning, so he couldn't be here. And to thank everyone for coming as well. It's been a tremendous conversation. Thank you so much, Tulip, for your moderation as usual. Absolutely brilliant. Tulip is an amazing journalist and a very brave one. It's been wonderful to for you to be doing this. So thank you to everyone and for coming. And I do hope that this will help, along with many other things going on, really shift the needle on this conversation and take it forward a bit.
Thank you, and thank you to everybody listening and watching on YouTube. There's a lot of passion in this room, great will to help people and to help people help themselves, and to, it seems like a very sensible, obvious argument, but as you pointed out from DFID, it is clearly multifaceted and has a lot of challenges. But thank you all. Thanks for those taking part online. I think we're here for a couple of hours for those that want to stay and chat.
If people want to spend some time talking to each other, getting to know each other, you're very welcome.
Lovely. So Professor Piot, Dr. Fox, Dr. Gamhewage, Dan at the bottom there, Caroline, and of course Raphael as well. Thank you very much for taking part. Thank you.
It came out.
Yeah, it was fine.
It's a bit dramatic.
I forgot that you had it.
I had no voice.
Makes people listen up a bit.
Yeah. And I really did have to sit through it. So frustrated. But I couldn't talk.